Thank you all for joining us today for ToxTime. My name is Carissa Little, and I am one of the account managers here at USDTL. Today's presentation topic is about newborn alcohol biomarkers. And presenting today, we have Dr. Joseph Jones, Chief Operating Officer here at USDTL, who will be joining us live shortly. We also have Aaron Murray, one of our business development managers, who will be the moderator for today's presentation. We now welcome Dr. Joseph Jones.
Thank you, Carissa, and thank you everyone for joining us today for this version of ToxTime. And so I'm excited to present to you today a very, very important topic concerning newborn toxicology. Today, we would like to talk about the detection of newborn alcohol biomarkers for the purpose of identifying newborns that have been exposed to ethanol in utero. Fetal alcohol spectrum disorders is a group of neurological, behavioral, and physical abnormalities that are caused by prenatal alcohol exposure. Most instances of FASD are quite subtle and are not apparent for many years, while there are few that are very obvious early on. These children show a group of facial dysmorphologies where the eye openings are narrow, the upper lip is unusually thin, and the upper lip is smooth, missing that little dimple that most people have. The ears are also sometimes lower. Originally, we only recognized the most obvious of these cases and referred to them as fetal alcohol syndrome, or FAS. Over time, we've come to appreciate the broad range of these effects and now embrace that concept by calling it fetal alcohol spectrum disorders. FASD is the leading cause of mental deficit in this country, and it is the only cause that is 100% preventable. So how prevalent is maternal drinking? Here's a study published by Ethyl et al. Back in 2009 using the National Birth Defects Prevention Study. This was a study that was sponsored by the Centers for Disease Control. It was a case control study between 1997 and 2002 that collected self-report information from over 4,000 mothers. They only selected mothers who had live births with no obvious signs of defects. They chose this group of mothers because they were hoping to get as accurate a self-report as they could. If the mother had perhaps consumed alcohol during pregnancy and there was no problem, maybe she would be a little more likely to be forthcoming with that information. So they captured the information from these mothers for the 3 months prior to conception all the way through delivery. What they found in this study was that 30.3% of the mothers self-reported that they drank some during the pregnancy. 8.3% reported that they binge drank during the pregnancy, with a binge drink being 4 or more drinks in 2 hours. And lastly, they had 0.5% reported that they binge drank during the 3rd trimester. Now, one thing that was interesting here is that binge drinking was not associated with income. And so this is an issue, we all know this, that alcohol use disorder, it knows no boundaries when it comes to socioeconomic status. So here's another look at the estimation of the prevalence of maternal drinking. The Behavioral Risk Factor Surveillance System, or BRFSS, is a study also sponsored by the Centers for Disease Control. This is a nationwide study that is conducted annually, and it is primarily conducted via telephone interviews. They conducted over 400,000 interviews, and what they were looking for was women in the 18 to 44-year-old range, and that study included over 20,000 pregnant women. So they asked them if they had had at least 1 drink of any alcoholic beverage in the past 30 days. And what they found between 2011 and 2018 was that this number had increased from 9.2% to 11.3%. They also asked them if they had binge drank during this period of time, during the past 30 days. And they also, during the same time period, saw an increase from 2.5% to 4.0%. So we're seeing that binge drinking is perhaps going up a little bit amongst the maternal demographic. So these two previous studies give us two very different looks at the estimation of maternal drinking. The first study asked questions of women who had given birth to obviously unaffected children and getting a retrospective self-report. And the second one was real time, focusing on the last 30 days. And so we can imagine that a lot of those mothers maybe had recently found out they were pregnant, but they had been drinking prior to finding out. So these are two very different studies. And it's also important to understand that just because the baby is exposed to alcohol does not automatically mean that they will express a FASD when they're born. So the next obvious question is, okay, so what's the prevalence of FASD in the U.S.? So here was an excellent study conducted by May and his team looking at the prevalence of FASD in 4 very different U.S. communities. It was an active case ascertainment, so they didn't wait for cases to come to them. They went to find the cases. They interviewed over 13,000 first graders, and they were looking for the 4 primary domains of FASD. So what are those? And so the 4 domains of FASD is there abnormal physical growth? Is there dysmorphic features? Are we starting to see some neurobehavioral development issues? And do we have evidence of prenatal exposure to ethanol? And so what May and his team found was that the prevalence estimates ranged from 11.3 per thousand births all the way up to 50 incidences per 1,000 births. So this was a lot more than was originally estimated prior to this study. And so what this study means for us is that there could be between 3.3 and 16.6 million people in our 332 million person U.S. population. So this is a lot of people that may have FASD. And so why are we concerned about this? Well, FASD is a huge public health burden. These children have difficulties in school. They express mental health issues. They have lower levels of productivity. They have higher rates of unemployment. They have higher rates of substance abuse issues down the line. Their rate of homelessness is highly elevated from the rest of the population. And this group has an increased contact with the criminal justice system. And so this paper by Greenmeyer and his team estimated that the average cost of FASD in this country is $68,000 per person. So that's a lot of public health money on something that is 100% preventable. Identification of prenatal alcohol exposure is key for the early diagnosis. The earlier we determine that a child has been exposed, the sooner we can refer to evaluation and treatment. There are treatments that seem to work for younger children, most likely due to their neuroplasticity. But all of that treatment research has been limited because of the use of maternal self-report or frankly other inadequate measures of alcohol use as a means to identify these children. Currently, the most frequently used mechanisms to identify prenatal ethanol exposure is maternal self-report. Most facilities use a standardized intake form, which has a couple of questions about alcohol ingestion before and during pregnancy. Obviously, there is underreporting due to stigma and self-incrimination. The direct measure of ethanol itself has a detection window of a couple of hours. Ethyl glucuronide and ethyl sulfate in urine may go back a couple of days. And there are a battery of indirect biomarkers such as CDT, GGT, and MCV, which unfortunately are confounded by pregnancy. A handful of organizations have used fatty acid ethyl esters and meconium as a means to identify prenatal alcohol exposure. But there are several issues with using fatty acid ethyl esters as well as meconium. Fatty acid ethyl esters are not stable in light or temperature, and they form in vitro if the meconium becomes contaminated with ethanol. There's also a significant chance of a false positive with late collections because of fermenting microflora invading the gut following delivery. They make ethanol and the enzymes convert that to FAEE, no drinking involved. Most recently, there's been the use of ethyl glucuronide in umbilical cord, and this seems to be a better way for the detection of prenatal alcohol exposure. So what are fatty acid ethyl esters? They are a group of non-oxidative metabolites of ethanol, so they're very specific for ethanol. They have a prolonged half-life, and they are indeed biomarkers of ethanol exposure. They accumulate in a variety of tissues, with fetal meconium as one of the examples. Meconium is the newborn's first bowel movement. It begins forming in weeks 12 to 16, occurs within the first 48 hours following birth in most cases, but there can be delayed passage for some neonates, especially if they're premature. Unfortunately, the transition from meconium to milk stool sometimes is not that obvious, and so we need to make sure that we're testing meconium and not milk stool. But there are several issues with using meconium. Meconium can be passed in utero. It can just simply be missed. The sample collected may not be pure meconium, as I just mentioned. Fatty acid ethyl esters are sensitive to photo and thermal degradation. And then unfortunately, there is the possibility of postnatal FAE formation if there is contamination with ethanol. And that ethanol could come from developing gut flora in the newborn. There was a paper published in Alcoholism, Clinical and Experimental Research a few years ago that demonstrated just that. So there's a lot here on this slide. Let's take them one at a time. In chart A, we're showing that the more ethanol we add to a negative meconium, the more FAEE are produced. So we're demonstrating here that we're able to take postnatal collected meconium, add ethanol, and we can form FAEE right in the cup or in vitro. They also looked at storing it at different temperatures. And so if it's stored at 25 degrees or room C, or if it's stored at 37 degrees, you get more production at 37 degrees. So that's consistent with the concept of in vitro formation. Also in chart number C, they looked at how long you let it incubate. So the longer it incubates, from 2 hours to 4 hours, you create more fatty acid ethyl esters. So just these three experiments here are clear that there's activity going on in the meconium after it's passed, and if you add ethanol, if it gets into the meconium somehow, you can form fatty acid ethyl esters. So you have to be very careful about using alcohol-containing products in and around the collection of the meconium. The chart looks at the same experiment, but using meconium that was the first meconium passed versus meconium that was collected later. And so in chart A here, the top two charts are early samples where they were just allowed to incubate for 2 days. No FAEE were created. And then they added some glucose, and again, no FAEE was created. If we look at the bottom two charts here, same experiment, except these meconium were late passages of meconium. And just on standing, we can see that a couple of these specimens produced FAEE. And then if you add a little bit of glucose, you can see that several of these meconium samples produced positive levels of FAEE. So there's something going on between the first passages and the second passages. And what they concluded was that the gut is invaded by microflora, and that these are, in some cases, fermenting microbes. Another interesting view of this phenomena is we have several babies here, and they collected the meconium, they charted the time that they made the collection, and they tested each passage separately. And on the x-axis is the time following birth, and the y-axis is the amount of fatty acid ethyl esters. 2 is the cutoff using the units of measure of nanomoles per gram. So we can see also that they noted that the first samples are noted with the white square, and then the subsequent samples that were collected are indicated with the black dot. We can see that up to about the 18-hour mark or so that there were no positives in this group. And then we start seeing some sporadic positive results throughout, but notice that all of the white squares following the 18-hour mark are below the cutoff if they were the first specimen to be captured. The conclusions from this report was that fatty acid ethyl esters are proportional to the added amount of ethanol. The amount of fatty acid ethyl esters are proportional to the post-collection timing, and that they were concerned with false positives with the mean time to appearance was at 60 hours, and the time to first appearance of a false positive fatty acid ethyl esters was at 19 hours. So what do these conclusions mean for us? We should only collect meconium up to 18 hours. We do not want to mix any of the subsequent passages into the original cut because it may contaminate the specimen with either ethanol or fatty acid ethyl esters. So only collect meconium for the first 18 hours following birth. Now, if you have a specimen that was collected after 18 hours, if the result is negative, then it's acceptable. But at our laboratory, we do our screening, and if the specimen is positive, we then refer back to the requisition form, and we see if that specimen, if there were collections made more than 18 hours following birth. If it was, then we reject it at that point, and you get a canceled result back for the fatty acid ethyl esters. About 15 years ago, we began transitioning from using meconium as a newborn toxicology specimen type over to umbilical cord, specifically tissue segments for the newborn toxicology specimen type. Unfortunately, in umbilical cord tissue segments, fatty acid ethyl esters seem to not be present. We looked at a number of other alcohol metabolites, and the one that seemed to best serve to monitor for prenatal alcohol exposure was the metabolite ethyl glucuronide. So ethyl glucuronide, or EtG, is a non-oxidative metabolite of ethanol. It has a prolonged half-life. It's a very specific marker for ethanol. It accumulates in a variety of tissues and fluids, such as hair and urine, and umbilical cord tissue is one of those specimen types that it accumulates in. So just to give you an idea of what we see with ethyl glucuronide in umbilical cord tissue, our original paper that we published back in 2012, we analyzed 308 specimens, and out of that group, we had 12 positive EtG specimens, which is 3.9%. The median concentration of EtG in these specimens was 21 nanograms per gram, and the concentrations ranged from 4 nanograms per gram all the way up to 666 nanograms per gram. We also found that concentrations were consistent along the cord, so we could take multiple segments of that single specimen and we would get the same result all the way down the cord. Post-collection formation, we exposed 3 specimens to ethanol vapor. We incubated it for 2 days at room temperature, and unfortunately we also get post-collection formation with EtG. On those 3 specimens, those results range from 11 all the way up to 201 nanograms per gram. So what this means for us is that we've got to be very careful about collecting and storing the specimens. We cannot allow them to be exposed to ethanol in and around the collection or the analysis at the laboratory. Here's another paper in the literature about the detection of EtG in umbilical cord. This study had 59 authentic specimens that were from a high-risk demographic, and out of that group, they had 25 specimens that were positive for EtG, and those concentrations ranged from 4.4 nanograms per gram up to 529 nanograms per gram. So even though the positivity rates were very different because they were different groups of study patients, the concentrations that they found were relatively similar to what we found several years earlier. So what do we see here at USDTL day in and day out? Here's a chart that shows our positivity rate or prevalence over the past couple of years. And you can see that the mean positivity rate is 1.9% plus or minus 0.23%. So this has remained rather consistent over the last several years here at USDTL. If we look at a breakdown of the concentrations of EtG in U-cord, we see that the vast majority of these specimens are between 5 nanograms per gram and up to 183 nanograms per gram. And then we can see a long tail of outliers of very elevated results following that primary group ranging from 5 to 183. So one of the questions that typically comes up is, have we seen any effects of COVID with what we're seeing with ethanol? There are many studies out there that show that the amount of binge drinking and relapse and evolving into alcohol use disorder has been somewhat elevated over this COVID pandemic. Additionally, the number of people that are seeking help has been dramatically reduced, primarily because of social distancing and self-isolation. So we saw that the prevalence rates didn't really seem to be that much affected during COVID. So we took a look at the concentrations that we found. So these are the quarterly mean concentrations going back to the first quarter of 2019. And as we can see, the concentrations do bounce between the mid-30s to the mid-50s. But we did see a trailing increase going from the first quarter of 2020 up to the fourth quarter of 2020, with a significant drop back down during the first quarter. So I'm not sure if this is related with COVID, but it certainly does seem to fit other patterns that I've seen with self-report data in the literature. So the follow-up question to the previous chart is, was that increase during 2020, was that a statistically significant observation? So the appropriate test for this is a Kruskal-Wallis test for independent samples. And what we're seeing here with the p-value at 0.784 is that no, it is not a statistically significant difference, and that chance does explain that to a great degree. So my follow-up question is why did we not see a significant increase of drinking in the maternal population during the COVID experience? Does it have to do with sample selection? Did we not get all of the samples that we would have normally gotten? Was this maternal population somehow a little more protected from alcohol use disorder than other demographics? So there'll probably be research conducted for years on this, or maybe our observation, the number of cases, we just don't have enough cases to form a statistical opinion. So I find it interesting that there was not a statistically significant increase in either the positivity rate or the concentrations during this period of time. So in our laboratory, if we compare our prevalence of EtG in umbilical cord to other drugs that we find in umbilical cord, we can see that EtG is kind of in the mid-range here of some rather concerning compounds. At the roughly 2% average, that's similar to what we find with cocaine and a little less than fentanyl. When we attend scientific conferences concerning drug testing, we tend to focus on drug testing and not that much on alcohol. And the point of this chart here is showing that alcohol needs to be part of the conversation when we're talking about substance use and misuse. So that's the purpose of this chart here. So now that we're nearing the end of our presentation, the next question might be, well, what can we do next? Well, one thing you could do is visit our website. Our clients have told us that they appreciate the amount of information, specifically infographics, posters, news articles that we've accumulated on our website over the years. Please feel free to download and use and distribute any of that material as you see fit. We're very happy for you to do that. The next thing would be you could call the number listed below and talk to client services about what testing options are available to you, and make sure that if you want to do alcohol testing, that it's part of your pricing agreement with USDTL. If you need to understand how to order alcohol biomarker testing, contact your account manager, and Carissa would be more than happy to show you how to order this test. And if you've never sent a sample to USDTL, please feel free to call or email the email address below to set up an account at USDTL and begin sending specimens to us.
Like and subscribe to our channel to receive notifications about new videos.